All right, we will go ahead and get started for today. My name is Laura Seth, and I'm the Marketing Director here at Aptitude. I wanted to welcome everybody to our Aptitude 2020 webinar, August edition of our webinar series. We're excited to continue to host these interactive sessions. And for those of you that don't know us, I'm going to take a moment here to tell you a little bit about Aptitude, and then I will turn it over to our guest speaker for the day. So Aptitude is an approach that many of the nation's larger, sophisticated purchasing organizations are leveraging to accelerate their supply chain activity. It's a process that's being adopted by value analysis teams, contract managers, supply chain professionals, and clinical staff. As a result, providers are effectively managing their PPI strategy, accelerating value analysis structure, gaining line of sight into opportunities, and viewing market trends to better align with the right strategic partners. It's an all-encompassing approach. From cross-references to responding to bids, it's all streamlined into one platform, resulting in a simplified, more efficient contracting process. And it also accelerates and delivers speed to contract. Standard T's and C's means less time in legal, and again, the single platform creates efficiencies that result in 60% shorter contract cycle. We also offer analytics to create meaningful dialogue and transparency into contract performance. It creates a single source of truth for you and your suppliers to align your goals and have informed conversations. So now let's turn it over to our content expert for today's webinar. Joining us today is Anushka Dasgupta, Associate Director, Research and Development with MTF, and she's going to discuss how MTF Biologics is reshaping the future of acute and chronic wound healing. So give me just a moment here, and I will pass this over to you.
Okay, thank you very much, Laura.
Absolutely. Okay, you should be able to share your screen now.
Okay. Thank you very much, everyone, and thank you so much for this opportunity to present our exciting allograft options. In this presentation, we hope to share how we are continuing to strive to kind of unravel the mysteries of these aseptically processed allograft tissues, showcase the advantages, and share our insights of clinical effectiveness. Happy to answer any questions at the end of the presentation. I realize some of our audience members might be having lunch, so just want to give a heads up that we have a few images from our clinical trials to help kind of demonstrate how we achieve closure over time, and then I'll try to give another heads up prior to kind of showing the image. And so with that, I'll begin. So our objectives.
Anushka, I can't see your screen yet. Would you mind trying to share that again?
Oh, okay. I'm so sorry.
Oh, that's all right. Just thought I'd let you know before you go in too far. Go up in the top line, hit share.
Oh, I thought I did. I'm sorry. And then share content.
Right. And then share content. Yeah, and then probably select. Yeah. There you go. Now you're coming through. Perfect.
Okay.
There you go.
Sorry about that. Thanks. I thought I had done that. Okay. No worries. Okay. So again, with that, hopefully through this presentation, these are some of the key objectives that we hope to kind of go through. What distinguishes MTF Biologics allograft tissue forms? Hopefully through the presentation, we'll able to kind of hone in on that. Why we chose placental tissue form, what is unique about a reticular dermal cut and the architecture associated with that. Why we're thinking about adipose tissue and what's kind of unique about fat. And hopefully throughout this presentation, you'll get an appreciation of how the allograft tissue is processed. That's very important. And then we understand your pain, which is the health economics, and we'll share with you how we're, appreciating that area too. Okay. Somehow it's not letting me go to the next slide. Okay, there we go. So who are we? So we're the largest tissue bank in the U.S. We've recovered over 132,000 donors and counting, and distributed more than 8.6 million grafts. In terms of industry standards, we maintain the highest. We've been founded and governed by surgeons, and the uniqueness is that we have a very stringent donor criteria. The three principles that we kind of live by is we want to make more safe tissue available to our customers, provide the highest quality tissue, and advance the science of tissue transplantation. And this is the crux of what the founding surgeons had in mind, and they continue to govern these three principles to date. And so what is unique about driving these 3 principles is the way we process our tissue. We do this without any irradiation through aseptic processing alone. So there's no terminally sterilization at the end of our process. This helps to preserve and protect the biological and mechanical integrity of the allograft tissue. So in terms of our evolution, many of you know us as the Muscular Transplant Foundation. That is also how we're known. And we were founded by just providing orthopedic tissue forms. But in the last several years, we've now evolved and expanded our portfolio to include plastic and reconstructive surgery, and our latest addition is wound care. But as you can see, that we've had over 30 years of allograft experience, 20 years of the living cellular tissue forms, over 13 of dermal, and now 7+ of placental tissue. We are a nonprofit organization founded by these surgeons, and again, we continue to try and understand all the tissue forms that can help our patients. In terms of how we approach things, we are different by design on 4 different pillars. 1, philosophically, we're a nonprofit organization. Science drives us, the patients are focused, and those are the 2 key ways we kind of achieve that goal, being a nonprofit organization. Our patients are our key customers, the clinician, and the feedback between the 2. Scientifically, we have a lot of expertise in processing our tissue. We do this aseptically to preserve the tissue and maintain its structure as close to the native tissue form as possible. We have a lot of extensive research to follow, and hopefully this presentation will share a little bit of that. Clinically, we have robust level 1 clinical evidence. Again, we must show you that we're effective, and we have these level 1 RCTs to help, guide us with that. And then lastly, economically, again, we're committed to value-based outcomes and realize that that's a very critical point of health economics. In terms of different types of wounds, staggering number and different forms, surgical, chronic, lacerations, burns, traumatic types of wounds. And, the key thing for us is like the growth rate of these types of wounds and the number of days that it takes to actually heal them. So again, our goal is to help close these wounds as quickly as possible to kind of prevent any kind of infection and escalating costs that are associated with that. So what are factors influencing chronic wounds? I'm sure the audience here knows these. I just want to kind of highlight them. So in terms of key factors that kind of stop wounds from kind of healing, the first one is infection. So if you have infection, that's going to prevent the native tissue from actually healing and the cells from doing what they need. So that has to be taken care of first. Secondly, prolonged inflammation. So there's a lot of toxic proteins in the environment, proteases that kind of prolong this inflammation into an unhealthy version. We need inflammation. The body needs to know how to fight the inflammation, but we need that to be a healthy form. So when it's more prolonged and pro-inflammatory, that's a hindrance in how the body knows to heal itself. Thirdly, lack of blood supply. Again, the blood is providing oxygen and nutrients to that wound bed, and when that is insufficient, you don't have the energy needed to actually drive you to the finish line of wound resolution. And so all these 3 factors affect how the cells will function, and therefore, it's done in a very non-organized fashion and leads to wounds not being resolved. If you take a look at the right image, you can see an ulcer that's been open for 36 weeks, and that's with standard of care treatment, just gauze, debridement, and primary and secondary dressings. And nothing was being resolved. This patient already has comorbidities, a few digits missing, and so, very long time that this ulcer is being open. Next phase would be amputation of further digits or the foot. With treatment of our aseptically processed AMNIOBAND membrane, weekly treatments, this wound healed in 6 weeks. So what was the allograft tissue able to provide that the standard of care was not, and in such an expeditiously fashion? Well, what's missing are all these biological cues, and that's the advantage of allograft therapies in general. So in terms of what's missing are the matrix proteins, the growth factors, the signaling components, and sometimes in very chronic and high-risk patients, it's probably the cells that are, doing the right thing. So it's very important to preserve these cues in the allograft tissue, and that leads us to how you process the tissue matters. And so MTF's approach is that we want to provide the safest tissue, but we want to provide the highest quality tissue because that will provide a solid foundation for your wounds to heal. And we do that by aseptically processing the allograft tissue without any form of terminal sterilization. So the tissues are not irradiated at all. So now moving on along into our different tissue forms. We'll start with placental tissue. Why do we consider placental tissue? Well, it's actually a very amazing tissue form. There's inherent biological properties in the form of the matrix proteins, growth factors, and cells. Its natural function is to protect the baby and the mother, so it's a protective barrier. And it's readily available, and it's coming from pre-screened living patients, so you know how the mothers are doing over the trimesters. And actually has a very long clinical history, as you may know. Some of the earliest documented papers date back to 1910 of it being used as a dressing. In terms of biological properties, again, it's very well published. You'll see 4 main themes. It's non-immunogenic, as in it does not create any immune response. And it does not have proteins that would be deemed foreign when implanted. It's an anti-adhesive, anti-scarring properties. It minimizes the amount of fibrosis. There's a lot of anti-inflammatory components that help reduce inflammation. This is probably the biggest advantage in placental tissue. And then fourthly, antimicrobial properties. And again, that makes sense. The baby is being protected for 9 months. And so, there should be a nice protection guard. And so if you process the tissue in the right, gentle manner, you can actually preserve all these biological properties. So that leads us to our placental platform, which involves a dehydrated amnion chorion sheet or membrane, that is AMNIOBAND membrane. AMNIOBAND particulate, which is a particulate version of amnion chorion that's dehydrated, and then our cryopreserved AMNIOBAND viable amnion only. And so I'll take you through each of these different tissue forms. So we'll start with our dehydrated options. That is the AMNIOBAND membrane and particulate. Again, if you think of the key features and benefits, the first one is that its naturally inherent biological components are preserved, and we believe that they work synergistically together to facilitate wound closure. With the particulate, the reason why we created that is many clinicians were just cutting up the membrane and creating their own confetti, and so we thought that we could do that for them. And again, this is targeting the unique topographies of the wounds, undermining, tunneling, and able to really conform to the different complex topographies. And again, the second punch is that we are aseptically processing. There's no irradiation, and so that preserves the natural scaffold and integrity, and again, provides you safe, high-quality tissue. So the advantages of aseptic processing is that, again, terminal sterilization, while it's focused on achieving safety, does that at the cost of the quality of the tissue. And there's articles published out there that due to the extreme heat and radiation, that denatures the tissue structure and the matrix proteins, and that also compromises the binding sites for the cells to attach and the subsequent signaling that goes on. And so that tissue is now altered from the native unprocessed tissue. With aseptic processing, we are providing you the most similar tissue to the native unprocessed tissue. So you're similar to the autograft tissue form. Achieves the same sterility assurance level, so 10 to the minus 6. Sterility assurance level of 10 to the minus 6 means 1 in 1 million chance that there's a bug present. And usually that's the same category as terminally sterilized tissue. We validate this. We have also published this. And, so we know that the tissue form is safe and at the same time, we're able to preserve the tissue structure, matrix proteins, and signaling cues. And we've also published on that part too. So we're giving you the safest tissue with the highest quality, and that helps provide a solid foundation for subsequent wound closure to occur. How do we know this? Here's some data to help demonstrate that aseptic processing preserves the natural scaffold. We have in the first box, numbered 1, it helps preserve the natural collagen matrix. So if you were to kind of, melt the allograft tissue, expose them to high temperatures, the collagen structure is going to unfold. You can see in here the native and AMNIOBAND, they behave very similar. So they have similar ways of being affected by high temperature. And so that means that the collagen structure is pretty similar to the native tissue, and it's not different. Once you terminally sterilize the tissue, whether it's E-beam or gamma radiation, the temperature decreases, and so that's indicative of the collagen structure being different, or it now has decreased collagen stability. So again, this is some evidence to show you that the way you process the tissue will affect the collagen matrix structure, and that can be again, impactful in how wound closure occurs. The second panel helps show you that we retain a lot of the key matrix proteins and growth factors. You can see the abstract art of brown and orange staining in each of those little panels that help provide evidence that we have those specific proteins that help guide those native functions of anti-inflammatory, antimicrobial, angiogenesis, proliferation, and stabilizing inflammation. Again, this is very well documented, and we have references for that. And thirdly, they're preserved at levels similar to native. So the orange bands are the native tissue, and the blue bands are our amnioband membrane. So you can see those levels are very similar and comparable. Second, how does amnioband actually support wound closure activity? So 3 things that occur. The first is it supports granulation activities, and that means that the cells are able to secrete a ton of new matrix proteins, and you can see that in the first panel where the first box is just the tissue, so there's no cells, and the second one is at 1 week, you can see that brown staining. That is the contribution of your cells, and that's happening because the cells like the amnioband membrane, and they're being triggered in the right way to produce new matrix proteins that are found in the granulation bed of wounds that are undergoing closure. The second thing is, how does it support angiogenesis and angiogenic activities? And that means the formation of new blood vessels. Here you can see in our basal media, there's no exposure to any growth factors, and our endothelial cells are just dots. You can see green fluorescent dots. But when you actually extract components from our membrane and expose them to the cells, you get these beautiful web-like tube formation. That is indicative and classic evidence of new blood vessel formation. So this is very encouraging that the way we've processed our tissue retains all those angiogenic proteins that would trigger blood vessels to form new blood vessels. The last thing is supporting epithelialization activity. So that means keratinocytes, which are our skin cells, they need to migrate. They tend to be very stubborn, and they tend to just kind of proliferate and hyperproliferate around the wound edge, and so they don't, tend to migrate. So here we expose cells to amnioband, and we expose them to nothing, just basal media, and we saw that there was greater migration when exposed to amnioband membrane. And at the same time, when you culture these cells on the tissue, you can see that brown stain again is indicative of the matrix proteins they need to secrete to then close the wound. So epithelialization activities involve migration and production of matrix proteins to close that wound. And so again, these are all the key activities that would help wound closure, and amnioband membrane supports all angles of that. How does the particulate support this? And the question was, do we need to sprinkle the particulate particles all over, or can you just sprinkle it? So do you need to fully cover the wound? And so here, through our studies here, we were able to show that you actually get cells to attach to the particulates, and they actually respond to the biological components and start bridging nearby particles. And you can see that over time, they're able to actually cover the overall wound, and that's helping lead wound coverage and wound closure. So now going on to our AMNIOBAND viable. Again, we have that trinity of cytokines, matrix proteins, and growth factors. Here, the viable endogenous cells are here and joining the party, and so it's providing a complete biological solution. And here it's just the viable amnion that is cryopreserved, again, aseptically processed because we want to preserve the viability of the cells. We've done some characterization, and we see that in terms of how we process, we're processing it gently to maintain all the cells that are found in the unprocessed tissue, and then you can see the AMNIOBAND viable. The total number of cells are the same, so our process is gentle enough. Are the cells functional and viable? We did some cell studies where we put the AMNIOBAND viable on a Petri dish, and you can see the graft in the corner, and you can see the cells actually migrate out of the graft and come into the Petri dish and start proliferating, and over time, it basically covers the entire plate. And lastly, again, all those biological components that I was talking about previously for the dehydrated format, they're also present in the biological format. So again, this is the viable option. And the way we process it, we ensure we have viable functional cells that retain all those biological components. So now let's move on to some of our RCTs, our level 1 clinical evidence. We've done this with the AMNIOBAND membrane. This is an 80-patient trial. And we saw that at the end of 12 weeks, 85% of patients healed and performed better than the standard of care, which is just debridement and gauze. 4 applications or fewer were needed for closure. The really exciting thing was you got to see about 90% wound reduction in the first 4 weeks. Now that's an indicator of, if the wounds are going to close, how the wounds behave in the first 4 weeks. And we're seeing generally half the time to closure. And again, all these results were published, and we can have these available to you. In terms of cost and health economics, we understand this to be very important. And we have 13 different sizes that can match the wound size, and this helps to kind of reduce the cost. And the way we process this also helps to kind of reduce the number of applications. So you can see that at the end of 12 weeks, the mean graft cost to closure for our AMNIOBAND membrane is the lowest, published at $17.71. And this is 85% less than DERMIGRAFT, 80% less than ALLOGRAFT, and 37% less than the terminally sterilized tissue form EpiFix. In terms of wound area reduction, again, we achieve a much greater reduction within 4 weeks, and we're doing it with fewer treatments. Again, the way the tissue is processed helps the tissue to reside longer, and that's where you're also seeing that there's fewer treatments needed to achieve closure. In terms of, this is just to put up some images of our results from our clinical trial. Again, you can see at week 1, pretty open wound, and over time you can see that the wound is healing. And at the end of 6 weeks, this wound is healed, and when clinicians are actually putting their thumb against it, they felt that there was nice resistance, so your thumb would not sink into the wound, and the skin quality was feeling pretty good. So again, 6 weeks needed to close a 36-week open ulcer with weekly treatments. And all these patients came back for a validation visit. And again, that was to kind of prove that the wounds were actually closed. So in terms of AMNIOBAND offerings, we have 13 different for the dehydrated membrane. For AMNIOBAND viable, you can see we have 5 different sizes. And for AMNIOBAND particulate, we have 3. So now moving on to our dermal tissue form. This is ALLOPATCH PLIABLE, and this is coming from our deceased donors. The skins are recovered from the back, And we actually go deeper because clinicians were telling us that the superficial layer where most acellular dermal matrices are cut from was not integrating well. And so we went deeper in to make sure we're 100% reticular, and we aseptically processed the tissue, and we found that that deeper layer kind of opens up the structure and allows more graft infiltration and integration to occur. And by going in deeper, the tissue is more uniform, and that allows the tissue to be applied without any polarity issues. So here we go. Here's how we kind of prove that. As you go deeper, you can see that the reticular dermis is more uniform and open on both sides. With the papillary dermis, it's dense on the top, and it's more open on the dermal facing side. So there is asymmetry, and you need to know which direction you're applying the graft. But with the reticular dermis or our ALLOPATCH pliable tissue form, there's no sidedness. Again, all those preserved proteins are found. They're the brown staining that you can see. And we also quantified a couple of key proteins that help stabilize inflammation and promote cell function. And again, all these results have been published in our paper. In terms of helping you to understand that the structure of the dermis impacts cell attachment, we've done studies to show that the reticular layer, you get similar cell attachment on both sides, whereas with the papillary or superficial layer, you're actually getting more cell attachment on the more open dermal side and less on the epidermal side. And again, that makes sense because it's more open, allowing greater cell attachment, which then again will translate in greater incorporation over time. So how does ALLOPATCH pliable support wound closure? Well, it's unique because it's the reticular structure cut. It's open architecture, and it's uniform on both sides, and that really helps facilitate native host integration, so the cells are able to attach, infiltrate into the graft, secrete the right matrix proteins. You can see that in brown. And then lastly, they're also able to support angiogenesis because all the right angiogenic proteins are preserved in that ALLOPATCH matrix. And so, again, you can see these beautiful wound vessels, new blood vessels inside the graft, and that helps to kind of revascularize the graft quicker over time. Again, here's our randomized control study, and we looked at diabetic foot ulcers similar to the AMNIOBAND study over 12 weeks, and here we saw 80% healing, significantly better than the standard of care, healing again at half the time, and then this cost to closure is $1,200. So again, very economical compared to the key tissue forms out there, DERMAGRAFT, ALLOGRAFT, and EpiFix, sitting at $1,200. And again, we understand the health economics, and we have several sizes to meet that. So here is, again, some clinical evidence that demonstrate wound closure over time. And you can see, again, with weekly treatment, the wound, this wound in particular took about 5 weeks to heal, and then the patient came in for a validation visit, and the wound remained healed. Again, clinicians were saying that the skin felt supple. There was nice resistance, so your thumb did not go in. So good kind of organized healing, again, was observed. Here are different sizes, 4 different sizes to, again, match the different wound. So now finishing off with our adipose allograft matrix. Here we have off-the-shelf allograft matrix. It's a natural material, sort of allows host tissue ingrowth. It consists of adipose-derived matrix proteins devoid of any lipids and cells. Basically, it corrects any defects subcutaneously in the space where native fat already exists. And so here you have kind of the tissue unit. It's a syringe with the allograft adipose matrix, and there's an accessory kit, and you kind of go through and hydrate the tissue. Its clinical convenience is that it's ready to use in minutes, easy to store at ambient temperature. For patients, there's no donor site morbidity because you don't need to take lipoaspirate from another site. And the adipose matrix basically eventually models to become the patient's own tissue. In terms of clinical need and where it can be used, reconstructive aesthetics in the face, breast, and body, for small volume defects, such as liposuction, cellulite dimples, and for scar revisions and wound care. So a little bit of characterization, again, through aseptic processing, we're able to retain those key biological proteins, and those are important to allow for adipogenesis, so new fat formation, and angiogenesis. In our studies where we actually grew cells on the matrix, we were able to see great cell stretching. So here you can see the blue dots represent cell nuclei, and the red staining is the stretching of the cell cytoskeleton. So that's indicative of the cells liking that matrix and stretching and covering all aspects of the surface. They're also, over time, producing adipose tissue that's similar morphology to classic images you would find in textbooks. And they also, over time, differentiate. So if you put human-derived adipose stem cells, they're actually differentiating into mature adipocytes, and they're also functional over time. So the last corner image, you can see the green fluorescence, that is fat. That means that the cells are actually depositing lipids over time, and the stain is to show that they're functional. Here's an animal study to show you that over time, an area that had no adipocytes actually is rich in adipocytes. So you can see at 3 weeks, wherever you see those white rounded areas with the arrows pointing, that represents the adipocytes. So at 3 weeks, you see some minimal infiltration and neovascularization. By 6 weeks, you see more adipose infiltration. By 12 weeks, that area is now covered with more of those white spots all over. And again, this is subcutaneous injection, and this is helping us to understand that you definitely get adipocytes where there was just the matrix before. And so this helps to kind of rebuild the fat area. Here is the stain. Again, if you have mature adipocytes, you're going to be staining positive for perilipin A, and you can see the beautiful red staining throughout. The blue is staining for nuclei, and so you can see area that was devoid of cells is now full of native cells and functional adipocytes. Last bit is to look into kind of our in vivo human assessment, and we did this at 10 patients where we injected at 6 sites in the abdomen, and these are patients that are undergoing adipoplasty later on, and we were trying to evaluate if the adipose allograft matrix injected would actually allow new adipocytes to form, and we also wanted to check the rate of any complications or any adverse effects. So as you can see here, over time, you basically see that adipocytes form in an area that adipocytes were not. So in the first image, you can see that there is where the adipose allograft matrix is. You can see AAM bolus. That's where that native tissue, the injected tissue is. And you can see that adipocytes are actually forming on the periphery. And there's a little bit of a capsule that's formed, but fat cells are forming on the periphery, and this is happening at 12 weeks. At the end of 24 weeks, you can see that the whole area is now full of cells. So, and that capsule is much thinner and much less prominent. And so this is all host infiltration, and so that matrix is so powerful to kind of help allow new fat formation in that area that is just cells. And so this is great evidence to show that adipogenesis is occurring throughout that whole injected area. And lastly, to help kind of support fat pad atrophy, we had done a study with Dr. Armstrong in Los Angeles. He was trying to see that after you heal an ulcer, can you kind of prevent any reoccurrence occurring and kind of, again, restore a fat pad. So you can see from this pressure mapping that there is a hot spot in red and sort of yellow. And so the adipose matrix was injected into that area. And you can see that over time that area is kind of, padded up, and you see the 70% decrease in peak pressure mapping in that area, and no evidence of any kind of callus that's retained in the long run. So again, providing a nice fat pad restoration and preventing, further re-ulceration is another big area that this adipose matrix can support. Again, we're very dedicated to science, so we have a lot of peer-reviewed literature. And so all of these papers are available if you need any, and we are continuing to publish. Again, hopefully this presentation helps you see that we're very different by design, both philosophically, scientifically, clinically, and economically. And if you have any questions, our key points of contact at MTF Biologics are Lisa Ledoux and Amy Sepp. And with that, thank you so much for your attention. And if you have any questions, I'm more than happy to answer them.
Yes, thank you so much. That was extremely educational. And like you said, I would like to go ahead and open it up for questions right now. You're welcome to either unmute your lines and use your phone, or you can use the chat function here on the WebEx.
Okay.
Yes, did you have a question? Well, if not, like I said, Anuska, if you want to maybe go back one slide, leave the contact information up there. If anybody would like to contact you guys directly, you're welcome to. If you have any questions related to what they have on contract with Aptitude, you're welcome to send that over to us as well. You can either use my email address that came through on your email, which is laura.seth@aptitude.com, and I'll get you to the right person, or you can always use ask@aptitude.com. And I will take one final call for any questions. All right, with that, well, then we will give you back a few minutes of your day, and just wanted to thank everybody again for joining us, and thank you so much, Anuska, for that wonderful presentation. It was extremely informative.
Thank you so much for the opportunity. And again, if there's any questions, we're more than happy to answer them. And thank you again for this opportunity.
Absolutely. Have a good day. We'll talk to you soon.
Bye-bye.